I'll just read the housekeeping items and then I will let you introduce the panelists. Good afternoon, everyone. I hope you are all well. We welcome you all to our session. This is session 10 of the Oxygen Therapy and Critical Care, the case-based series. And these sessions are brought to you in collaboration with Assist International, University of New Mexico, Institute of Health Sciences, Stanford Medicine, Division of Global Anesthesia, and Global Anesthesia and Critical Care, the Learning Resource Center. So a few items to remember: we will be using the chat function for question and answers at the bottom of the screen. Please send your questions through the chat box and also feel free to introduce yourself. If you have any IT issues, you can send a message through the chat to Echo India for assistance. And also remember that the session is being recorded and your attendance is consent to be recorded. We thank you and we welcome you all. Dr. Ananya, please.
Yeah, thank you, Kevin, for housekeeping. Welcome, everyone. Our today's session is going to be part 10, obstetric consideration for oxygen therapy and critical care. This is going to be a case-based discussion. Together with me today, we have two panelists, Dr. Mahalet Taddese. She's a cardiothoracic anesthesiologist in Addis Ababa University, and also Dr. Isaac Abraham, anesthesiology and critical care specialist at Addis Ababa University. I will give them time to say hello and maybe introduce themselves as well. So, Dr. Mahalet.
Okay, thank you, Dr. Ananya, for the kind introduction. So I'm Mahalet, I'm an anesthesiologist. I work at Blackline Hospital at Addis Ababa University, and I would like to thank everyone for their attention and welcome to this session. Thank you.
Thank you. Dr. Isaac.
Okay, and good afternoon, everyone. For those of you in Ethiopia. So my name is Isaac Abraham, and I'm an anesthesiologist currently working at Rambasa Specialist Hospital. And thank you for having me. I hope we will have a good session.
Thank you. So these are our panelists. So we'll be sharing, our today's. Yeah, I think our slide is visible now.
Yes.
As usual, we will be using, a case to discuss on obstetric considerations. So our today's case will be a 28-year-old pregnant woman who presents with fatigue and shortness of breath. So, before, discussing in detail, let me tell you some facts regarding maternal health. This is from World Health Organization. So as you know, maternal mortality is unacceptably high. Every day in 2017, for example, approximately 810 women died from preventable causes related to pregnancy and childbirth. So we need to understand that maternal mortality is very high. And the majority of mortality also occurs in low middle income countries. Around 94% is occurring in low and middle income countries. And it is also highest for adolescent girls from age of 10 to 14. And pregnancy related complications are quite common in this age group. And there is inequity in access to quality health service. And the skilled care before, during, and after childbirth can save lives of women and newborns. So this access to quality health service should be, implemented in setups like us in order to, improve maternal health and reducing maternal mortality and morbidity. So our today's session is also, the goal is to, care for the mother and reduce such unwanted morbidity and mortality. So as usual, we have this 11 listed practice change objectives. So by the end of the session, we will be able to list the physiologic changes that occur with pregnancy. We'll be able to describe how physiologic changes of pregnancy affect maternal well-being, and also how this physiologic changes of pregnancy affects disease presentation. We'll be able to describe the changes in arterial blood gas that occur during pregnancy. And after doing that, we'll be able to list the goals of oxygen therapy in pregnant women. We'll be able to recognize and describe signs of maternal distress as well as fetal distress. As we are talking about maternal health and maternal care, then we are talking about two individuals, the mother and the fetus. So recognizing, signs of maternal distress and fetal distress is quite vital in our management. So we'll be able to do that by the end of this session. And we'll be able to list, the multidisciplinary team members who are required to create managing critically ill pregnant mother. And also we'll be describing the unique consideration during resuscitation of pregnant women. So resuscitation of pregnant women is not as the same as non-pregnant women, and we'll see that by the end of this session. And the use of cognitive aids will also be well discussed, and afterwards we'll be encouraging you to use cognitive aids in emergency situations, and we'll be able to access COVID protocols for obstetric patients. So these are our objectives for today. Then let me start with the case in detail now. This is a 28-year-old pregnant woman with a gestational age of 29 weeks who presents with fatigue, shortness of breath, and her symptoms started 2 days ago with a stuffy nose, meaning rhinorrhea, and feeling of fever, although she has not checked her own temperature. Her pregnancy has been uncomplicated, but now she is concerned that she does not feel much fetal movement for the last day. She's a teacher. She's not aware of any exposure to SARS-CoV-2, but she does interact with children daily as she's a teacher. And obstetric history is 2 previous uncomplicated term deliveries. Past medical history, she's having hypothyroidism and no past surgical history. And social history, she lives with her mother and her 2 children and her husband in the same home. And there is no allergy. Medication, she's taking levothyroxine as she's hypothyroid. Now, in the next few, cases, questions, we will be able to cover, the 4 major objectives of this session, which will be understanding, the physiological changes in pregnancy and how this affects the maternal well-being as well as disease presentation. And among the physiologic changes is arterial blood gas, and we'll see what will happen in arterial blood gas. To do so, there are sets of questions following, and I will invite our panelists, Dr. Mahalet, to go through those questions. So, Dr. Mahalet, the floor is yours.
Okay, thank you, Dr. Ananya. So we'll start off with exercising some physiologic questions. So we have a question here. I'll read out the question, and please, the audience, try to give your answers in the chat box, and we'll give some minutes for each question and discuss it. So the first question is, each of the following are normal physiologic changes for pregnant patients' cardiovascular system, except A, increased cardiac output due to increased heart rate and stroke volume, B, dilutional anemia from increased plasma volume, C, supine hypotension syndrome, D, aortocaval compression by the gravid uterus, and E, increased blood pressure due to high systemic vascular resistance. So out of all these options, which one is false regarding the physiologic change cardiovascular physiologic change a pregnancy might induce. So I'll give some minutes, some seconds for our audience to give their answers in the chat box.
Yeah.
Okay, well, I'm finding some answers, and I would say almost 100% of our audience answered E, which is the correct answer, of course. So in pregnancy, we would not be anticipating or expecting increased in systemic vascular resistance, right? In fact, we would have the reverse because of the progesterone effect of relaxation of the systemic vascular resistance. Otherwise, the other answers, as correctly as as all of you mentioned, they are correct. So we will expect an increase in cardiac output. Both the heart rate as well as the stroke volume would increase. So heart rate usually increases by around 40%. Cardiac output, we might expect it to increase by more than 40%, 40 to 50%. Stroke volume would increase. So almost all parameters are increasing. And of course, there's going to be dilutional anemia from increased plasma volume. So as you remember, both the plasma volume as well as the RBC mass increase, but the proportion is significant in case of plasma volume. So because of this, our pregnant ladies will usually have dilutional anemia. And the other, of course, is supine hypotension syndrome. So this is mainly because of the aortocaval compression by the gravid uterus. And if the collateral vessels are not that much grown, then in some proportion of patients, when they lie supine, they would have hypotension and they would manifest symptoms of hypotension. So that's why, of course, we always recommend our pregnant ladies to always avoid the supine position, which includes during delivery and during CS as well. They need at least a little bit of alignment so that to avoid this orthocaval compression. So we can go to the next question. If we scroll down a bit. So the second question would be, each of the following are normal physiologic changes for pregnant patients, respiratory system, except the first, decreased oxygen consumption, B, increased tidal volume and respiratory rates, C, respiratory alkalosis, D, decreased functional residual capacity, and E, rapid desaturation during periods of apnea. So out of all these options, which one is false regarding the respiratory physiologic change during pregnancy? So again, feel free to drop your answers in the chat box. Okay, so I'm getting some answers, and I think almost all of you are saying, almost 100%, everyone is saying A, so which is also the correct answer, right? So in pregnancy, we would not expect the decreased oxygen consumption because of the high metabolic demand for the mother as well as for the fetal circulation, the oxygen consumption also significantly increases. When we look at the other options, of course, we would also expect increased tidal volume and respiratory rate. So when we come to respiratory rate, we don't expect that much increment, and most usually it stays the same, but the tidal volume is significant. So because of this, they will also have increased in minute ventilation. The tidal volume might increase up to 45% from their baseline non-pregnant state. The other is, of course, respiratory alkalosis. So this would also be correct because of the hyperventilation. These patients, their PCO2 would decrease, and they're usually predisposed to having respiratory alkalosis, which usually becomes compensated by the end. The other is decreased functional residual capacity. Of course, this is also true. So the FRC would decrease by almost 20%. So this would predispose them to easily desaturate during periods of apnea, and this could be significant when we are intubating these patients. And overall, their oxygen reserve is quite limited, and they can easily go into respiratory failure. And the last option, of course, is rapid desaturation during periods of apnea. So again, this is correct, like I said, because of the decreased in the functional residual capacity combined with their increased oxygen consumption, they can easily desaturate during periods of apnea. So can we go to the next question, please? Okay, so the next is true or false. So it's the question asks, dyspnea is common during pregnancy, occurring in 60 to 70% of healthy pregnant women. So is this a true statement, or what do you think? Please drop your answers. So when we say dyspnea, it's a subjective symptom, by the way. Does your patient usually complain of breathlessness or shortness of breath? So it's a subjective complaint. Okay, I'm getting a few answers. So almost everyone is saying true. So this is actually true. So because of the different physiologic changes we mentioned, as well as the different anatomic changes of pregnancy, most pregnant healthy women expect some kind of dyspnea. They report having a feeling of air hunger or slightly out of breath. So this is purely normal, and it's expected. This is mainly because, you know, the gravid uterus is also pushing the diaphragm, which would kind of restrict the movement of the diaphragm as well as splint it. This would be combined with their increased oxygen demand and respiratory drive. They usually feel a bit out of breath because of their high respiratory demand in combination with the anatomical change expected in pregnancy. So 60 to 70% of healthy pregnant women could have or report a feeling of dyspnea. So the next question is, pregnant patients have an increase in their tidal volumes and respiratory rates through normal physiologic change of pregnancy. So what change would you expect to see on the arterial blood gases? So what kind of change would we expect in the pH, in the PaO2, in the PaCO2, in the bicarb? We've been mentioning they have high minute ventilation because of their significant increment in their tidal volumes, right? So what do you expect? So I'm seeing PaO2 will increase. Okay, any other from our audience? Please feel free to give us a comment The problem is I know we are not usually routinely practicing arterial blood gas because of the unavailability of the arterial blood gas analysis, but just okay. So I'm getting more answers. Okay, I'm seeing also respiratory alkalosis. I'm getting an answer that PaCO2 would decrease to 27 to millimeter of mercury. More respiratory alkalosis with compensatory metabolic acidosis. Okay, I'm getting PaO2 will not be more than 100 and PaCO2 will be around 30 centimeter of water and slight alkalosis. Bicarb decreases from 28 to 22, PaO2 up to 101 respiratory alkalosis. Okay, so okay, great. That's a good participation from our audience. So almost every answer is correct. So like most of you pointed out, we would have during pregnancy there will be hyperventilation because of increased in chiral volume, and this would affect mainly the PaCO2, right? So that's very good. So on the screen we can see the arterial blood gas in non-pregnant as compared to pregnant patients. So as you can see, the PaCO2 in the non-pregnant, the normal would be around 35 to 45. But in pregnancy, this physiologic change of hyperventilation will start to ensue even from the start of the pregnancy around first trimester. So we would see a decrement in the PaCO2. It would be around 28 to 29 in the first trimester, and in the third trimester, it would be 27 to 32. So always remember that, for example, if you get a PaCO2 of, let's say, 40 in a pregnant lady who's in her third trimester, this is actually abnormal for her and she is hypoventilating, because the normal level of PaCO2, even at third trimester, would be around 27 to 32 millimeter of water. The other is the PaO2. The PaO2, it does not have that much highly significant change. As you can see, in the non-pregnant state, it could be around 90 to 100. There's slight increments, might go up to 106 in the first trimester and 101 to 104 around the third trimester. When we look at the pH, so as you know, the normal pH is around 7.35 to 7.45. And there will be slight alkalosis because of the hyperventilation and the decrement in the PaCO2. So as you can see, it would be around 7.4 up to 42 up to 7.46 in the first trimester, and usually goes around 7.44 around the third trimester. So slightly in the respiratory alkalotic range, but as a compensation, you can see on the bicarb. So in the normal patient, in the normal person, the bicarb is around 22 to 26, but as a compensatory mechanism for the decreased PaCO2 in the respiratory alkalosis, we would have some level of metabolic acidosis. The physiology would we would lose bicarbonate by the kidneys. So as you can see, in the first trimester, it's around 18, and around the third trimester it would go around 18 to 21. So this is usually the normal blood gas analysis anticipated in pregnant ladies.
Thank you, Dr. Mahalet. So participants, you can refer to this material in the Learning Research Center, Physiologic Changes During Pregnancy. So it has got everything you want regarding each system. And this is what Dr. Mahalet goes to, the cardiovascular, respiratory, and ABG changes. But other systems are also here. So I encourage you to read on that. So let's proceed with our case and question, Dr. Mahalit.
Okay, so the next question would be, can you list some obstetric causes for dyspnea and acute respiratory failure? So again, I turn to my audience. So we did say that dyspnea is very common in pregnancy. Up to 70% of our pregnant ladies could have some symptoms of dyspnea, but this does not necessarily mean that it's always the normal dyspnea, right? So we might have some pathologies associated concomitantly with our obstetric patients. So what could be some of the obstetric as well as non-obstetric causes for dyspnea and respiratory failure in this patient group? So I'm getting an answer. So I'm getting amniotic fluid embolism, correct, pulmonary edema. We are seeing underlying disease, exacerbation like asthma, pulmonary embolism, peripartum cardiomyopathy, dyspnea of pregnancy. We're seeing preeclampsia and amniotic fluid embolism. We're seeing pulmonary edema secondary to severe preeclampsia. So I'm getting very good, interesting answers here. So of course, pulmonary edema could be secondary to hypertensive pregnancy disease like severe preeclampsia. It could be secondary to concomitant underlying cardiac lesions, secondary, for example, secondary to valvular lesions or what have you, right? It could also be in patients on tocolytic treatment. We could also expect tocolytic related pulmonary edema. So it could be both cardiogenic as well as non-cardiogenic causes. So I'm getting severe preeclampsia. Diaphragm is pushed upward, definitely. Fluid overload. So this is also one of the causes, right? It could be iatrogenic because of unnoticed too much fluid running in our pregnant ladies who have been admitted on being put in IV fluid. The other is peripartum cardiomyopathy, possible. Again, pulmonary embolism, pneumonia. Pneumonia could be either normal community acquired or it could be due to aspiration pneumonia. The other is good answer I got is anemia of pregnancy again. So that's also correct. So like we mentioned, they normally have some dilutional anemia, and because of any other concomitant illness or nutritional aspects, if they develop anemia, they could easily go into decompensation during labor or delivery. So this is also correct. Amniotic fluid embolism, true. So we have to look for other signs and symptoms like DIC and petechial rash and other things. Pulmonary edema, PE, magnesium sulfate toxicity. So that's also correct, especially when we have our patients, our preeclamptic patients on magnesium sulfate, especially if their renal function is compromised. We have to suspect that as well. I'm getting valvular heart disease, amniotic embolism, large oxygen demand due to high metabolic state, plus any respiratory compromising illness. Definitely, they have very, like we mentioned before, they have very small respiratory reserve. So anything could push them over the threshold and they can easily go into respiratory compromisation. So it could be asthma or it could be simple reactive airway disease causing bronchospasm or what have you. So we've gotten really interesting answers over here. So we can have a look at the material provided there. So like all of you mentioned, it's not only dyspnea, physiologic dyspnea, right? So these are patients, they could have other illness as well. So this is a good table showing us by system and what could be some of the differential diagnosis. So if we go by head, the HANT system. It could be angioedema, anaphylaxis, pharyngeal infection, deep neck infections, foreign body, neck trauma. As you know, in preeclamptic patients, they would already have airway trauma, edema, so they could easily, with some slight infection or anything, they could easily go into develop dyspnea, chest wall, rib fracture, flail chest, pulmonary system. We have COPD, asthma, or patients with already pre-existing disease. We also have pulmonary embolism, pneumothorax, pulmonary infections, pneumonia, ARDS, contusions, lung tumors, pleural effusion is also some of the causes. When we look at the cardiac causes, we have acute coronary disease, could be MI as well, right? Heart failure, flush, pulmonary edema, cardiomyopathies, arrhythmias, valvular dysfunction, cardiac tamponade. When we look at some of the neurologic causes, we could be stroke, it could be neuromuscular disease, toxicity, or it could also be the cause, like for example, organophosphate poisoning, salicylates, carbon monoxide, diabetic ketoacidosis, sepsis, anemia. These are common things. Miscellaneous or hyperventilation, anxiety, hemomedestinum, intra-abdominal, and like we said, pregnancy, the normal pregnancy physiology could be there, and massive obesity could also cause dyspnea, especially during positional when the patients are lying down. So these are some of the obstetric as well as non-obstetric causes of pathological dyspnea in our patients. So like we said, because of most of our pregnant ladies, they already experience some dyspnea, we have to do a thorough history, physical examination, and look at our blood gases, look at our radiologic examinations to pick out those pathologic causes as compared to the normal physiology. And we have to act fast because, like we mentioned, they have very limited respiratory reserve. So if you want additional review of the maternal physiology, we have this resources. So we have the WFSA anatomical and physiological changes in pregnancy, and we have this lecture as well. So back to you.
Thank you, Dr. Mahalet, for thoroughly going through the physiologic changes of pregnancy. And special emphasis has been given to, dyspnea and what could be the cause, obstetrics or non-obstetrics, or even a normal pregnancy can lead to dyspnea in 60–70% of the cases. So these are the materials, as Dr. Mahalet said, and you can refer it later. So progressing into the next part of our session, I will give you a case update. So this is going to the same patient. Assume that now the patient's found to be having contractions, but they are irregular and occur approximately every 8 to 12 minutes. Her cervix is closed on exam. Maternal vital sign, temperature is 38.9 degrees, heart rate 115, blood pressure 140/75, respiratory rate of 18, SpO2 91% room air, and fetal heart monitor heart rate of 125. Now, with this case updates, our objective is going to be to list the goals of oxygen therapy in pregnant women, describe signs of maternal distress and fetal distress. Okay, so I'll go through the questions which can help us, to discuss this objective. So my first question regarding this will be, according to the Society for Maternal Fetal Medicine or Fetal Maternal Medicine, a group of high-risk pregnancy experts, what is the goal SpO2 for pregnant patients? So you can write it on the chat box. So what should be our goal of SpO2? This is something by the fetal medicine experts. And Yeah, so 94%, okay. Jonas and you are so saying above 94%, right? Okay, very good. Any other person who wants to try? Greater than 95%. 94, 95. Okay, Darsal, Daniel. So almost, most of you have found the answer. So you can refer, this guide by the Society for Maternal and Fetal Medicine. They have, explicitly wrote, how to manage COVID, classification of COVID, and what our SPO2 goal is. Pregnant women, they really require higher level of oxygen. As you said, oxygen consumption is higher because it's not only one individual, but the fetus is there, the placenta is there. Also, the maternal physiology is changed, a high energy is required. So the SPO2 level needs to be higher than the non-pregnant woman, and it is said to be above 95% is what our goal is, okay? So anything above 94, 95 and above is what we should expect the SPO2 goal is. So that means all of you have got it. We have discussed it also previously. So highly satisfied with that. Then the next question will be, can we make this one a poll question? Maybe, Kevin, if it's possible. So I'll read it out, like, which of the following oxygen delivery devices can be used in pregnant patients? Venturi mask, mask with a reservoir bag, nasal prongs, high flow nasal cannula, all of the above.
Bhavya, can we set up the poll?
Yeah, if the poll is not ready as well, you can write it in the chat box. So I'm seeing either Sal, E, second E, third E, fourth E, again E. That means all of the above. Yeah, anyone who wants to answer other than E? Yeah, I think every one of you are saying E. Yeah, definitely there is no any reason why we don't use those oxygen delivery devices in pregnant women. So all of the above can be utilized in pregnant ladies, and according to oxygen requirements and based on assessing saturation, we can scale it starting from the nasal prongs and nasal cannula, mask, venturi, and so on. So all of the above is the answer, and thank you for your participation. So let's give a case updates. So the patient is, let's say, placed on oxygen by nasal cannula now at 4 liters per minute. Initially, her SpO2 improves to 92 to 93%, which was 91. but an hour later, her requirement increases to 10 liters per minute by non-rebreather mask. Okay, you put her first on nasal cannula, then now you shift it to non-rebreather mask with 10 liters, and she was able to maintain SpO2 of 95%. So the health facility to which this patient presents does not have a neonatal care unit or a staff to care for a preterm baby, nor does it have an adult ICU. The decision is made to transfer her to a center with appropriate multidisciplinarity. Okay, having this case update in mind, now I'll proceed to the question. So the question is like, in one systematic review, 75% of pregnant patients who contracted COVID-19 were asymptomatic. Okay. Now, what are considered danger signs for pregnant women that should prompt her to present for clinical care? So, the literature is, those pregnant mothers with COVID-19, around 75% will not be symptomatic. But in what cases should the woman be presenting to seek for clinical care? So there are danger signs, right? It could be associated with COVID-19 or not associated with COVID-19. So can you name some of the danger signs? Chat box. Excellent. I am seeing vaginal bleeding. So a woman with vaginal bleeding should immediately see hospital facility. Leakage of liquor, yes. Rupture of membrane. Excellent. Change in mentation. So change in mentation could be sign of preeclampsia, eclampsia. Severe headache, yeah, blurring of vision, vaginal bleeding, decreased fetal movement. Yeah, this is also one of the danger signs. These are the things we tell our pregnant patients, to seek immediate medical care whenever they have this danger signs. Yeah, fetal as well as maternal signs. Okay, then bradycardic, yeah. So as a fetal distress, maternal bradycardia and so on, yeah, it could be difficult for the mother to pick that herself, but if she's in a health facility and she's dangerous, and blurring of vision, right upper quadrant pain, yes, high blood pressure as well, if measured at home. Okay, so if someone has, a home blood pressure facility, a home pulse rate checking facility, and saturation, if someone has a pulse oximetry at home, so high blood pressure, bradycardic, as well as low saturation level, should prompt them to come to hospital. Yes, and glucose abnormalities. So a lot of participation. Thank you. So maybe let's see some of the common danger signs here from our Learning Resource Center. If it's COVID-related danger signs, so anyone with difficult breathing, bluish lips or extremities, meaning cyanosis, who's gasping for air when speaking, coughing up blood, pain, pressure in the chest when not coughing, dizziness, altered mental status, or inability to eat, drink, or walk should be considered as a danger sign. Okay, when it's obstetric related, a mother in labor pain should seek medical attention. ruptured membrane, vaginal bleeding, decreased fetal movement, severe headache. Most of you have said these visual changes. Okay, convulsion or abnormal body movement, and persistent fever or unexplained abdominal pain should be considered as a danger sign. So if you want to see, this article is about, COVID-19 descriptive analysis, and it tells us, majority of pregnant women are not showing any symptoms for COVID, and it's on a British Medical Journal, and you can see the abstracts, and the finding here, results, and a particular interest will be conclusion. Pregnant and recently pregnant women with COVID-19 attending or admitted to hospital for any reason are less likely to manifest symptoms. Okay, they are less likely to manifest symptoms such as fever, dyspnea, myalgia, and they are more likely to be admitted to the intensive care unit or needing invasive ventilations than the non-pregnant women of reproductive age. So even though they are going to be asymptomatic, but once severely sick, as compared to the non-pregnant women, they are the ones who require, ICU care and ventilatory management. So that's why when you see a mother who is desaturating and requiring a high flow of oxygen, then you have to make sure that there is an adult ICU facility available nearby, or early transport of mother to that higher facility needs to be considered. When you think of the mother, then the second thing to think about is the fetus. Maternal distress can lead to fetal distress, and as fetal distress is a very broad term which can be used in many clinical situations. Although it's difficult to give a precise clinical definition, obstetrician usually use this term to indicate that the fetus is becoming hypoxic. So immediate delivery has to be considered, because neurologic damage may occur when fetal brain is deprived of oxygen. So antepartum fetal testing is used to assess hypoxia in high-risk pregnancies, and monitoring during labor supplies information on the status of the fetus prior to birth. So I'm sure all of you know how to, monitor fetal well-being. So my, next question will be about what are the options to monitor fetal well-being? What options do we have at our setup or at the setup you are working? Yes, so I'm seeing movement, fetoscope, CTG, Doppler. Yeah, so fetal movement is quite common to be used in our setup. Fetoscope to count for fetal heartbeat. CTG, yes. Biophysical profile, using ultrasound, okay. Someone also said Doppler. Topography, yeah, cardiotocography, CTG. Yeah, someone is saying all of the above, meaning those mentioned previously. Yeah, as you said, these are the commonest things we are using. So commonly available is using fetoscope. So you count for heart rate and determine if the fetus is bradycardic or tachy. But CTG for continuous monitoring during labor is one of the method utilized. Of course, fetal blood sampling can be used, as invasive procedure. We may not have that fancy practice in our setup, but this is something, from the presenting part, somewhere in the world they can do, they have this facility to do so. So I think you have mentioned most of the monitoring tools we have, but to consolidate on that, now let me give you, MCQ question. So which one of the following is a reassuring sign of fetal well-being? So late deceleration of fetal heart rate, loss of baseline variability in heart rates, fetal scalp pH less than 7.2, baseline fetal heart rate between 110 and 160 beats per minute. So it's going to be a poll question. So which one of the following is reassuring? So 9 participants, 10 participants so far all saying D. So that means all the others are not reassuring, okay? Yeah, great. So all participants answered the correct answer, which is going to be D. So let's see what's written, in the fetal heart rate monitoring. This is from the WFSA, weekly tutorial, and interpretation of cardiotocography. So from cardiotocography, at least what you can see is, baseline fetal heart rate, and it should be from 110 to 160 beats per minute. There needs to be, baseline variability, but it should less than 5. And yeah, so this is a kind of, something showing abnormal features in a CTG. So reduced or absent acceleration, presence of deceleration is something abnormal when you characterize CTG. And if you have the chance to see CTG, this is a kind of graph you'd expect. The lower one showing uterine contraction, and the upper one showing, the heart rate, if there is acceleration, and the baseline rate. So variability is expected, acceleration is expected, deceleration is not something expected, and the heart rate should range between 110 and 160. So you'll get all, the description in this document. So I think you need to go and read that. So our question really bases on, this table, what is reassuring, what is non-reassuring, and what is abnormal, okay, based on baseline heart rate of the fetus, variability in beats per minute, acceleration, deceleration. So absence of deceleration, presence of acceleration, variability 5 or more, and baseline rate of 110 to 160 is what is reassuring. Everything else is non-reassuring, and in severe case you can say also abnormal. So CTG is quite important, but in the absence of CTG, at least what it can do is using fetoscope and count for the baseline fetal heart rate and determine if there is abnormality or not. Of course, fetal scalp electrode, fetal blood sampling is something it can be utilized. Okay. Yeah, I think this is how we check maternal and fetal distress. If we say so, then let's proceed to the next practice change objective. It's about having multidisciplinary team member which are required for optimal care of a critically ill pregnant mothers. So can you list the multidisciplinary team members required for optimal care of a critically ill pregnant patients? So which team is really required when we are managing critically ill pregnant patients? Yeah, obstetrician, neonatologist, anesthesiologist, I agree. Intensivists, obstetrician, fetal-maternal specialists, nurses, physician anesthetists. Yeah, who else is required? Okay, nutritionist, excellent. Neonatologists to care for newborn. Midwives. Yeah, it's going to be a long list, okay? So all teams, the nursing physician, okay, obstetrician team should be there. So those who are, giving care at obstetric ward, it could be in the ICU as well, in neonatal ICU, even including, medical personnel, right? Cleaners. And the other staffs are also important. Nutritionist, very good. Clinical pharmacist, right? So yeah, you have got all the team, okay? So from this question, what we understand is this is going to be a teamwork. So in caring for critically ill pregnant patients, we need to have different experts and working harmoniously. So if you found this patient, so what monitors would you be placing on her? Okay, what monitors should be placed for this particular patient? Excellent pulse oximetry, ECG, blood pressure, standard DASA monitor, meaning pulse oximeter, ECG, blood pressure, okay, temperature, capnograph, and invasive blood pressure could be non-invasive and invasive. As patients critically ill, invasive blood pressure monitoring is also important. CTG, of course, for continuous fetal monitoring. Excellent. What else? So majority of the important monitoring tools is the standard ASA monitors have been suggested, yes, and all are correct. So maybe urine output monitoring, yes, as well as arterial blood gas. Okay, arterial blood gas monitoring is quite important. Excellent. So I'll proceed to the next question. So for the patient's transfer, she is placed in an ambulance. She is currently receiving oxygen by an rebreather mask at 10 liters per minute by an E-cylinder. The pressure on the E-cylinder reaches 2000 psi. How long will the oxygen tank last before it runs out? So this is a very practical question. This is so common for our practice that we tend to transfer patients in an ambulance, and we'll have a cylinder, and it's not uncommon, you know, to have an empty cylinder in the middle of our transfer. Or sometimes we'll be worried not to carry, you know, an empty cylinder because before delivering the patient to the appropriate place, the cylinder may get lost. So I'm seeing so many answers here about an hour, 66, 65, roughly an hour, 56. Yeah. So brave answers. So an hour and around is something, the correct answer, as you said. So, you know, in case of cylinders, the Boyle's law works, right? So P1 V1 is equal to P2 V2, meaning the pressure and volume in the cylinder changes in a constant fashion. So a cylinder of around 2000 psi for the E-cylinder, at this pressure, its capacity is around, you know, 660 liter. And considering that, and if we are using oxygen at 10 liter per minute, so to finish 660, around 60 minutes is enough. So 60 minutes turns out to be 1 hour. So if you click on a question here, you can find, you know, the capacity of different size cylinder, H cylinder, E cylinder, and how long it's going to be lasting. For the sake of time, maybe I'll proceed without showing that, but it can be readily available in the Learning Resource Center. But as many of you said, this cylinder by this flow rate 10 liters per minute, it lasts only for okay. So thank you. Yeah. So I mean, let's proceed to case updates now. So yeah. So let's say, unfortunately, the patient's status has worsened during transport to the hospital. She continues to contract intermittently and her cervix remains closed. Upon arrival, her status is as follows: maternal vital sign, temperature 39, heart rate 125, blood pressure 105 by 60, respiration 24, saturation is 90% on 10 liters per minute by mask with a reservoir bag. And you have less fetal monitoring availability, and heart rate is 105. There is variable deceleration and minimal variability. Now, you know, the next part of our session, basing on the case update I have already given, we'll be trying to cover objective to describe the unique consideration during resuscitation of pregnant women, how to utilize cognitive aids, and of course, COVID protocols for obstetric patients. So we'll go through, you know, questions. So let me invite Dr. Isaac.
Okay, thank you, Doctor.
So can you go along with the question?
Okay. So our next question is going to be list at least one unique intervention used during a maternal resuscitation. So I need you participate in the chat box, write down your answers. So at least one unique. I know there are lots of unique interventions used during maternal resuscitation. So what faculty said, left lateral position. Okay, I don't know, but you are doing a maternal resuscitation. So left lateral position is one way to tackle the supine hypotension syndrome. But imagine you are doing a CPR and so on. Could that be feasible? No. Increase oxygen support, PCM, cold compression. Okay. Okay, Amara said increase oxygen and prepare for intubation. Okay. So what's peculiar in the obstetric? Now you said prepare for intubation. Is there something that worries you during this maternal resuscitation regarding the intubation? Okay. Perimortem cesarean section. So that's one thing which is peculiar for the pregnant ladies. Okay, putting a 15-degree wedge on the right hip. That's more feasible than putting the patient on the lateral side. Okay. Any other different idea? Uterine displacement, excellent. Left uterine displacement is one thing which is also peculiar in resuscitation of pregnant women. Risk of aspiration, difficult airway. Okay, thank you, Tensai. That's also one thing which is peculiar in pregnant ladies. So the most experienced person should be intubating the patient. So IV above the diaphragm, yes, Jonas, thank you very much. Like we have talked during the physiology, obstruction of the veins below the diaphragm is a possibility. So securing IV lines above the diaphragm is one way to tackle that. So thank you for that. And obstetrician in the room, that is also a very good answer. Cold magnesium, okay. That's also if the patient was already on magnesium, it could be one cause for hypotension, cardiac arrest, so hold the magnesium. And holding the magnesium, what else can you do concerning the magnesium? You know, patients, they can easily go into magnesium toxicity while you are managing them for preeclampsia and eclampsia. So calcium gluconate, thank you very much. So calcium gluconate also has to be prepared. Yes, faculty also said calcium gluconate, okay. Yeah.
Yeah, so I think it seems like they exhaust everything, right?
Yeah, yeah.
So I'm particularly happy about, IV line above the diaphragm.
Yeah.
So if you put IV lines at lower extremities, and because of cover compression, it may not be reaching into the heart. So venous return is hampered. So that's good. That's, yeah. Anything else, Dr. Isaac?
I think they have all exhausted. Thank you. If we can click on the, we can have
yes, for the sake of time, I mean.
Okay, let's go.
Yeah, if there is no much to add, then we can have to go to case updates.
Okay. So next we have case update. So upon arrival to the hospital, the patient is found with continued contraction. Her cervix remained closed. She has now become more somnolent and it's difficult to arouse, and the following information is obtained on arrival. So we have an investigation, ABG, pH 7.34, and PCO2 of 40, PaO2 of 100 on 10 liters of per minute oxygen, and bicarb is 20, the full blood count is 20,000, hemoglobin is 9, platelet is 95,000, C-reactive proteins are elevated, AST are elevated, and chest X-ray showed multifocal bilateral parenchymal opacity. And with our fetal assessment, we see a fetal heart rate of 155, moderate variability, and recurrent variable deceleration. So this is our case update, and depending on this, we'll have next question, a true/false question. The following ABG is normal for this patient. True or false? The pH is 7.37, PCO2 is 40, PaO2 is 100, and bicarb is 20. So I don't know if you have a poll for this, or you can also write it in the chat box. Okay, Darshan said yes. True. Okay. So we have almost 5 people saying true and 1 said false. And in the chat box, that guy said false. Why? If you said false, then maybe if you can elaborate briefly. I know we have discussed the normal physiological changes in the arterial blood gases of the pregnant lady. Okay, in the polls, or almost 76%, 72% have said true. So, okay, false, and Yosef said false. Okay, Daniel said true. Okay, we have a reason. Normally, the pregnant woman is alkalotic. So, yeah, we are having a pH of almost like 14 right here, right? So we would expect it to be a bit lower, and for that you need to have a bit of compensation by the kidneys, which results in excretion of the bicarb. So we would expect a lower bicarb and a lower PaCO2. So as you can see from this table, you can clearly see that the normal PaCO2 for this patient who is currently in her 3rd trimester is usually in the range from 27 to 32. So this patient is having a PaCO2 of almost 40, so which is a bit higher than expected. So that's one abnormality we are having in this patient. So, and also the pH has also lower, 7.37 in this patient, but we would expect around 7.44 in this trimester. So this patient's having an abnormal ABG. So that's how we would conclude it. Okay, thank you all for your participation. We would go on to the next question. Okay, we have a case update. So the patient suddenly loses consciousness and she's emergently intubated for hypoxia and transferred into the ICU. She has begun to contract regularly every 5 minutes. Her cervix is closed, but there is small amount of blood noted at the vaginal introitus. So we have a vital sign update here also. Temperature is 39 degrees Celsius, heart rate is 120. Blood pressure has dropped to 95/45. Saturation is 95%. So she's currently on mechanical ventilator. With this setup, mode is pressure controlled ventilation and ACPC. FR is of 70%, respiratory rate is 20, and the measured tidal volume is 6 ml per kg. So we have a PEEP of 10 centimeter of water, and the plateau pressure is 35. And also on the fetal side, the fetal monitoring shows the heart rate of 105, which is a bit lower than we expect. And we also have a recurrent variable deceleration which we have also previously discussed as abnormal and minimal variability. So now we have a question based on this case update. So if these patients were to go into cardiac arrest, which one of the following modification is not appropriate during the ACLS for pregnant patients? So we have a choice and we have a poll. You can either answer the chat box or the poll. So, okay. So in the poll, 4 people said A, tilts the patient 30 degrees to the right during CPR. Okay. Okay, 10 people, 90 people, okay, almost 92% have said tilt 30 degree, and the other one, okay, 6% said CPR with 100 compression per minute. Also in the chat box, most people are saying A, tesfaye አታክልቲ ፍጹም. Okay. Okay. Thank you all for your participation. Okay. Okay, a different answer. B, manual left uterine displacement by a provider. Okay, so the poll has ended. So now I think we've clearly seen that, except A, most of all of the choices are usually necessary during a cardiac arrest and a resuscitation of a pregnant patient. Manual left uterine displacement is a very necessary to avoid the orthocaval compression by the uterus, and 2 large bore IV lines, as you've said, above the diaphragm, also to bypass this orthocaval compression, and CPR compression rates 100 per minute, which is no different from any other non-pregnant lady. So, but the choice A says that tilt the patient 30 degree to the right during the CPR. It's almost like impractical. I mean, there is no way we can do a CPR when a patient is tilted to any of the sides. So this is not.
Yeah, maybe Dr. Isaac now in ACLS guideline,
Yeah.
What they may recommend is, tilting the patient to left 30 degree left. The issue with right and left is placement of inferior vena cava. So inferior vena cava anatomically is found on the right side. So leftward tilt is highly recommended as it offloads the uterus from the inferior vena cava. So that's why where is the trick from this question. So that's also the reason why it is preferred by obstetricians and others who's giving maternal care for the patient to lie in the left lateral position, not even in cardiac arrest conditions, but the others are, according to the ACLS guide. So I have seen someone saying, CPR with 100 compression. I think the thinking behind that is it could be low compression. Maternal heart rate is slightly, higher. So 100 compression could not be enough. That could be the rationale, but still the ACLS stick with 100 compressions per minute, and it should be enough for this condition. But for safety of the fetus, as well as to improve circulation, and perimortem cesarean section early on in the CPR is also something recommended. So yeah, I think the poll was excellent.
Yeah. So we also have another question. We also have a poll. So in a crisis of clinical emergency, which of the following actions have you observed when a provider cannot remember how to manage a certain clinical situation? So we have choice from A to E. In A, call the colleague for help, use the internet on the phone or the computer, go through a textbook, hide or walk away, all of that. But have you seen your colleagues do any of this while they cannot remember how to manage a certain clinical situation? So all of the above, almost 50-50 with A, call a colleague for help. Okay. Okay, so okay, most of you have said call a colleague for help. I mean, that's more feasible. I mean, there is no way I can find a textbook around the bedside of my patients. So, okay, call a colleague for help, 57%. Okay. A, okay, that's fine. Also, this said A, Daniel said all. Okay. Also in the polls, almost around 60% of our participants said call colleague for help.
Yeah, if you give me a chance, I will say all of the above. The question says, which one of the following actions have you observed? So, you know, this crisis or emergency in obstetric patients, I mean, it's common. And also in such situation, people do all kind of activities because of stress, you know. I have seen a person who walks away from the stress, you know. So some tries, you know, internet and so on. This happens because you don't remember things at the time of stress and emergency condition. So I think it's based on, you know, personal experience. So many of people know when, you know, a colleague is being called, but these are also something people can do, right? What's your experience, Dr. Isak?
My experience, I would say A and B. I have seen many of my colleagues call for help and use the internet, the phone, the computer. But I've never seen anyone go through a textbook. So
yeah.
Okay, thank you. Next question we have.
Yeah, so what will be, you know, the message from here, you know, at emergency situation, you may not remember everything, but you want to do according to the guideline and the protocol, or you want to do the right things. So in order to help you with this, you need to have a so-called cognitive aids. Cognitive aids are, you know, small books like which are placed in the operating theater or in medical facility. And while you are giving care of the mother, you can ask your assistant to go through, you know, those cognitive aids. So if it's maternal cardiac arrest, for example, you can ask your assistant, can you go through maternal arrest resuscitation protocol? And he can assist you in telling the steps. Okay, first do this, then do that, and then do that. So in that way, you can be accurate enough in managing patients. Otherwise, in panic, you may not do whatever is needed and you may miss things. So yeah, such kind of, you know, manual is quite important, like emergency manual or the likes. Okay, we have a few of these materials in our setup, so everyone is encouraged to have this. The Learning Resource Center at least is obstetric anesthesia emergency manual and other cognitive sets are available. So it's free to download. So going through the Learning Resource Center, download it, print it, and place it to your area, and you can use it during emergency. And it's going to be quite useful.
Yes, yeah, thank you, Dr. Ananya. I think it can also be taken as a key why anyone is willing to do this. I mean, it can change and save lots of life. If you can print out and you can stick it into the walls of the labor wards or the OR, it can be a very good, useful material. And I invite all of our participants to go through this website, Stanford University, and check out their resources and go through them, and they can practice them in their future. They can become very good professionals who can manage patients who are in their cardiac arrest and so on. So thank you all. We will go through a case update, and okay, we have a case update. The patient is diagnosed with ARDS from the presumed SARS or COVID-19. She's placed on lung protective ventilation setting on mechanical ventilator, and maternal fetal medicine specialists are following the clinical status of the patient and the fetus. So we have a question here. One strategy to improve oxygenation in patients with ARDS is to place the patient in prone position. So is this possible in pregnant patients? Yes or no? Yes, from you. Okay, thank you. Anyone else with a different idea? And someone said no. Why? If you said no, I want you to briefly explain why. So Saga said yes, Amara said yes, Nancy said yes. Okay, thank you. Okay, that's fair. Difficult to apply, but possible. Thank you. And Mario also said yes. Nicholas said yes. Sisai also said yes. Thank you, everyone. Okay.
Yeah, if so many people are saying yes, we can see also the video, right?
Yeah, let's proceed with the video. Thank you.
Let's proceed with video. Is it audible?
No.
No, it's not audible.
Yeah.
I think maybe you can stop share and then you can share again. There's an option there which says share with sound. You can click that and then share again.
Okay, maybe I okay.
We will be demonstrating the prone positioning of an intubated pregnant patient. Note there are 5 to 6 assistants, 1 at the head of the bed, 2 on each side, and 1 at the foot of the bed if available. All movements will be made at the direction and count of the respiratory therapist or lead personnel at the head of the bed. This person is responsible for ensuring the security of the ET tube and support of the head and neck. For the proning maneuver, the patient will be turned towards the ventilator. First, a flat sheet will be placed underneath the patient by rolling the patient to one side, placing the sheet underneath so that it may be passed to the other side, and then rolling to the opposite side to complete the placement of the lower sheet. Once the patient is returned to the supine position, monitors including EKG electrodes may be removed. Next, 3 sets of pillows will be placed on the patient. The first 2 pillows are placed on the chest, the second 2 over the pelvic area below the gravid abdomen, and the third set over the lower legs. A second flat sheet will then be placed over the pillows and the patient. The assistants on each side will roll the two sheets together towards the patient, encasing her in the cocoon fashion. The sheets must be rolled tightly to ensure stability of the pillows during turning. Again, all maneuvers will be made at the direction and count of the person at the head of the bed. The next maneuver is to slide the patient away from the ventilator. The patient will then be rolled onto her side by the assistants on the ventilator side pushing under while the assistants on the opposite side push over. The person at the foot of the bed will help guide the feet. Once on her side, the assistants will switch hand position prior to the final prone maneuver. The assistants towards the ventilator will have their hands on top and pull forward and downward, while the assistants on the opposite side pull upward. Once prone, the head should be turned to one side and supported. Monitors can be replaced and the ET tube checked for security and patency. Pillows may be adjusted as needed. Next, we will check for space between the abdomen and the bed to ensure that the uterus is offloaded and fetal monitors can be placed. The arms can be positioned towards the head, down to the side, or one of each in the so-called swimmer's position. The head should be turned and the arms repositioned every 2 hours to avoid skin abrasions and pressure ulcers. All maneuvers can be reversed to return the patient to the supine position.
Yeah, so as you have seen in the videos, it's difficult to position the patient in this prone position, especially the pregnant patients or the obese patients. So we might have a similar concern as the patient with like obesity with round abdomen. So the basic thing is that we need to offload this abdomen by placing a mattress on the chest, as you've seen on the video, and also on the thighs, so that the abdomen can float, so that you can even put UCTGs on to monitor the fetus, and also helps with the respiratory mechanics. So if the abdomen is offloaded, the diaphragm can easily go up and down. So, these are some of the advantages of putting the patients in prone position. So, Dr. Ananya, if there is anything you add?
Yeah, I mean, yes, prone positioning is difficult, but it's not something it can't be done. So all our participants, it's good that they have considered prone position is a possibility. So whenever it's possible and whenever the benefit outweighs the risk, we have to utilize prone position. Saying so, let's proceed to the last question. Is going to be.
Okay. What other considerations are required when caring for pregnant patients with COVID-19? So you have listed most of our concerns. So finally, if there is anything you would also consider when you are caring for patients with pregnant patients with COVID-19. So we have gone through the physiology in pregnancy, the arterial blood changes in everything, prone positioning. So what else can you also consider something maybe we have not gone through this chapter. Daniel said no complications, fetal condition, labor. I think we have these patients also has strong continuous contraction, even though the cervix is closed, she's in labor. So fetal conditions also something we need to care. Okay. Ati said, thank you so much.
Someone was saying, infection prevention, so negative pressure, ventilation, and so on.
Okay, yeah.
Yeah, closed suctioning, and so infection prevention needs to be.
Yes, yes. That's also one consideration. So how else can you manage the patient? Also, if you can also focus on the patient.
Maybe Dr. Isaac, as we are running out of time.
Yeah.
So some people are even saying thank you so much. So
yeah,
we can finalize. You can add, considerations and
Yeah. Okay, thank you. So considerations in these patients, as you have said during the physiology, we have seen before that pregnant patients are hypercoagulable. COVID-19 also leads to hypercoagulability. So another consideration in these patients is the coagulation. So as much as possible, you need to anticoagulate patients who are COVID-19 pregnant patients. Even you can use heparin. So even up to 10 days postnatally is one consideration. Additionally, we need to have. The other thing is that, is it possible to have a vertical transmission of COVID-19? The answer is it does not. There could be viral infection of the placenta, but does not necessarily mean infection of the fetus or or any fetal harm. So there are cases in which there were fetus was found positive with COVID-19, but there was no signs of respiratory distress and so on, which was rare to find. The other is the endothelial condition and so on. COVID-19 has been also shown to affect the endothelium of the vessels and so on. So this might predispose the patients with COVID-19 to have preeclampsia and so on. So these are some additional considerations we can have in pregnant patients with COVID-19. Yeah.
Great. So thank you, Dr. Isaac. So there are also, additional resources for obstetric and COVID-19. So you can find this, the Learning Resource Center, the WHO Guide, National Institute of Health, Society for Maternal Fetal Medicine, American College of Obstetricians and Gynecologists, and COVID protocols are available. So these are a good reference material. So I think we have completed our practice change objectives. These were our 11 practice change objectives. We see, physiologic change of pregnancy, its relation with maternal well-being and disease presentation. We looked into a blood gas analysis and the goal of oxygen therapy, and we described, maternal distress signs and fetal distress signs, and need for multidisciplinary care for obstetric patients, and some of the considerations during resuscitation of pregnant women, and the need to use, cognitive aids, and some COVID protocols are going to be available for you when you refer the Learning Research Center, okay? So there is a good saying by Rosa Parks, like knowing what must be done does away with fear. So it's good to know what to do so that we won't be afraid of things. For this, cognitive aids can really help, it can give you good information at the time of crisis. Saying so, we'll end up our sessions here. I really want to thank all the participants to take your time and for good participation. And panelists, Dr. Isaac Abraham and Dr. Mahalet Taddese. who are consultants, physicians at Addis Ababa University, and all the supporting staff who made this presentation possible, from Assist International and ECHO India. So our panelists, Dr. Isaac and Mahalit, if you have anything to say finally as a final word, I'll give some minutes for you, and Kevin will formally close our session.
Okay, thank you, Dr. Ananya, and all our participants for their very active participation. And yeah, the time is running, so I'll just say have a good day and thank you.
Okay, I would also like to say thank you for all your participation as usual, and I hope you go through the resources we have posted on the chat boxes, which are very important on your future career. And thank you. Have a good day.
Yeah, maybe I have seen one final question, I guess, if our panelists wants to answer this, it's from Daniel Tadesse. What about physiological blood supply to the fetus on prone position? So the worry is when we are putting patient in prone position, would there be compromisation of blood supply to the fetus?
So in prone positioning, there are no the physiological changes are not going to be affected by gravity, because it's going to be the blood is going to come from the mother and go through the placenta into the fetus. So I haven't come across any of the literature, but on the prone positioning, there is not going to be any physiological change in the blood supply. If anything, it's going to improve because of the relief of the aortocaval compression. So that's my.
Yeah, if the mother is lying on the abdomen, then of course it's going to be a compression. But as it was seen on the video, the abdomen should be freely lying. That means the fetus is going to be away from, the aorta and vena cava. So aorta and vena cava compression can be avoided. But of course, proning has its own, hemodynamic effects that may be affecting the mother as well as the fetus. But you are doing this also to improve oxygenation. So because of that, when the benefit outweighs the risk, then prone positioning is a possibility. It doesn't mean that it's not without a risk, but you have to optimize everything, like optimize hemodynamic condition of the patient and do proper proning, then fetal compromisation can be minimized. So thank you for a very nice question. Thank you, panelists, for your time and for your detailed discussion. So now, Kevin, you can formally close our session.
Thank you. Thank you so much, Dr. Ananya and the panelists. So we have reached the end of the session, and just a few wrap-up comments. You can visit the Learning Resource Center to access all the material that have been presented, and also the link to the LRC and the recordings will be shared after this session by email. You can scan this community, you can join our community WhatsApp group by scanning this QR code here, or you can send a message to assist through the number shown on the screen. So we thank you so much. We urge you to join our next session, session 11, which is going to be held on 29th of March, 2022. And we are going to be discussing on essential emergency and critical care. For those of you who will have questions, you can email us at echo@assistinternational.org. Until then, we thank you so much and we wish you all the best.
Thank you. Nice.
Thank you. Thank you. Bye. Echo India team, I think we can close the session.
Sure. Thank you, Kevin. Thank you, everyone.
Yeah.